Good evening, everyone. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we are going to be talking about a once-daily oral JAK inhibitor for adults with moderate to severe atopic dermatitis. Our moderator this evening is Dr. Leon Kircik. Dr. Kircik is president of the International Dermatology Education Foundation and clinical professor of dermatology at Icahn School of Medicine at Mount Sinai in New York, Indiana University Medical Center in Indianapolis, and medical director of physician skincare, DermResearch, and skin sciences in Louisville, Kentucky. Our speaker this evening is Dr. James Song. Dr. Song is Director of Clinical Research at Frontier Dermatology Partners, Affiliate Residency Program Director at Silver Falls Dermatology, and Clinical Instructor at the University of Washington. We'd like to thank our supporter, Pfizer, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question using the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser and will be emailed to you 1 to 2 days later. We'd greatly appreciate it if you could fill it in and send it back to us. Finally, within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Again, if you want to submit your questions, use the question chat pane on the right-hand side of your screen, and I've written a note there so you can see exactly where you need to type in your questions. So without further ado, I will pass the floor virtually to Dr. Kircik.
Thank you, Roxanne, and good evening, everyone, and thank you for joining us for another series of International Dermatology Education Foundation educational programs. Tonight, we are very lucky to have Dr. James Song with us, who's going to be discussing CIBINGO. However, before we start, I do want to tell you a little bit about IDEF, International Dermatology Education Foundation. We are a non-profit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. We have had several programs in the past on this channel. As you can see, we have been in US, in Canada, as well as internationally in Asia, South America, and Europe. And we are continuing our programs virtually as well as live sometimes. And again, tonight, we're gonna join with Dr. James Song, who's gonna tell us all about CIBINGO. Dr. Song is the Director of Clinical Research at Frontier Dermatology Partners, as well as a clinical instructor at University of Washington. Welcome, James. Thank you so much, and take it over.
Thank you, Dr. Kircik. Thank you, Roxanne, and thanks to all of you for taking the time out of your busy evenings to join us today. Truly, I think we are now on the cusp of a golden era for atopic dermatitis, somewhat reminiscent of what we saw with psoriasis in the early 2000s, where we went from having 50% improvement being somewhat acceptable to now passing 90 becoming the standard. And I truly do think we are on that trajectory with atopic dermatitis as well. And if you look at the rates of getting someone to completely clear or almost clear, even with our biologic therapies, we're only maybe doing that 30 to 40% of the time, right? What do you do for the other 60%? And if you look in psoriasis, and I hate to make that comparison again, but we can do that over 80% of the time with our psoriasis therapies as monotherapy. And so that is really the level that we should be shooting for our patients. And I truly do believe that with the JAK inhibitors, with CIBINGO, we are going to bridge that gap and eventually catch up to where we are with our psoriasis therapies. And so with that, we'll get started. We're going to be talking about CIBINGO. This is a once daily oral JAK inhibitor that has preferential selection for the JAK1 isoform. And this is for adults with moderate to severe atopic dermatitis. And by way of disclosures, first off, this program is being sponsored and paid for by Pfizer. I'm being compensated as a consultant, And the contents of this talk, they're consistent with FDA guidelines, which really just means everything is meant to stay on label. Okay, and this program is not CME accredited, but I hope you still find some value in today's discussion. And so this is just a roadmap for today. First, we're going to talk about, what's the JAK-STAT pathway? Why are we interested in this? And what makes CIBINGO as a small molecule inhibitor different than perhaps the biologics that most of us are familiar with? We're going to spend a lot of time talking about the efficacy coming from the JADE clinical trial program. And there's 3 studies that were the pivotal ones that we're going to do a deep dive into. We're going to talk a lot about safety. And I think this is probably the one area that many of us just feel a little bit uncomfortable with when we get a new therapy. So we'll make sure we spend enough time here. And then just lastly, just kind of practical tidbits. What labs do you want to order? What are the things that you want to be discussing with your patients? How often and how should you be monitoring your patients? All right, so we're going to start off here looking at the indication. Okay, what type of patients are candidates for CIBINGO? And very simply put, this is for adults over 18 of age who are refractory, moderate to severe atopic dermatitis, and that's a clinical trial definition. But you, as a clinician that is not within the clinical trial, get to make that determination of what moderate to severe is, and that's just not a body surface area. It's just not an easy score, right? There are other things that you want to be asking your patients about, chiefly quality of life, right? And it's for those patients who are not adequately controlled with systemic drug products. There's a couple that are listed here, like biologics, but in no way is it saying that you have to be a biologic failure, right? And while those patients are candidates, if you've had a patient who've been on systemic courses of prednisone or steroids or cyclosporin, and they don't want to continue that therapy because it's not advisable to continue steroids or cyclosporin long term, those patients would be candidates as well. Now, you do see underneath here, there are some limitations to CIBINGO, mainly being that we just don't have any experience combining CIBINGO with other JAK inhibitors or other biologics or immunosuppressant agents. As you'll see, CIBINGO is actually just a monotherapy study, or you're able to use it with topical steroids. So we just simply don't have that experience with CIBINGO itself. As far as contraindications, this is the only one that you need to be aware of. Don't use CIBINGO with a patient that's on an antiplatelet therapy. Okay, so for example, clopidogrel for the first 3 months while they're on CIBINGO. Now, the exception to that is low-dose aspirin. And the reason here is that you'll see it in a small number of patients, the platelets levels do drop a little bit within the first couple of weeks. It hits a nadir at 4 weeks and it comes back up in 3 months. And so the idea here is that you just don't want to increase that risk of bleeding by taking an antiplatelet agent and also having someone being thrombocytopenic. All right, so now we're moving on to the important safety considerations, often referred to as the black box. And you're going to see a warning here with serious infections, mortality, cancers, major adverse cardiovascular events, and thromboses. Now, I want to make clear, this is the same box warning that's on every single oral Janus kinase inhibitor that's approved in rheumatology, GI, and derm. It's the same one that's on the topical JAK inhibitor as well. So I just want to make that clear. Now, if you look carefully at the language here, you're going to see this mention that there were higher rates of some of these adverse events, okay, with another JAK inhibitor versus a TNF blocker in a rheumatoid arthritis population. So where is that coming from? How did it make it into this package label? So last year, actually, the results of a 4-year ongoing post-marketing safety study that was required by the FDA was just published. And that study was primarily a safety study where they wanted to look at the rates of some of these serious side effects here. And they wanted to do it comparing a JAK inhibitor versus a TNF inhibitor. Now, because these things are so rare, though, they had to cherry pick their patients. They had to look for a very sick group of patients where this is more likely to happen. And so they took patients who had moderate to severe rheumatoid arthritis over the age of 50. You had to have at least one cardiovascular risk factor. You had to be on methotrexate, and up to 60% of these patients were on systemic steroids. And what they found was that the relative risk with the JAK inhibitor versus the TNF inhibitor was a little bit higher, but the absolute risk was still low, okay? So I think the question you really need to ask yourselves is, first off, is that patient population reflective of the type of patients that you are seeing as a dermatologist? That's number one. And number two is a pan-JAK inhibitor, which is the one that was being compared here, the same as the JAK inhibitor that we will be discussing today, okay? And so I'm gonna have you just reserve your thoughts and your judgment until we get to the very end, because we're gonna be looking at that safety data specifically in an atopic dermatitis population with a selective Janus-1 inhibitor. I'm getting a little bit of feedback there, so if you don't mind just muting yourself if you're not talking, that'd be great. All right, so one of the questions that I get asked the most is, okay, James, like, who is a CIBINGO patient for you? When are you considering, escalating to this therapy? And so this is obviously a fictional case, but I do think this does a really good job of illustrating the type of patients I'm considering using CIBINGO. So this is Tyler, he's 21, has moderate to severe AD, treated with topical steroids, been on an injectable biologic, but he's still not controlled, right? And I think that definition of still not controlled just depends on the provider, but also depends on the patient. That could mean maybe you're still itching a lot, maybe you can't go swimming or exercise. So it's not just a body surface area or an EASI score. All right, here we go. So one of the things that we've learned about atopic dermatitis is that compared to psoriasis, it's a much more heterogeneous disease. We have many more cytokines at play, right? It's not just IL-17 or IL-23. In atopic dermatitis, we have IL-4 and 13, which are important for barrier disruption, IL-22 for epidermal hyperplasia, IL-31 for itch, interferon gamma for chronic inflammation, and TSLP, it kind of helps maintain this Th2 pathway, okay? These cytokines all drive atopic dermatitis, and we know that IL-4 and 13 are important because you could block it with a biologic. And while some patients get better, there's still a significant percentage of patients that don't get better. And that is because you have these other cytokines at play. And then the one kind of thing these cytokines have in common is that they require JAK1 to transmit their message inside of the cell. And so that's really the rationale as to why we're blocking JAK1. Here we're showing you just a schematic of how this JAK-STAT pathway works. The best way to think about this is like a relay race. And so it starts from the outside of the cell. That's where the cytokine binds to the receptor. And then it's going to activate the Janus kinase pair, which then activates STAT proteins, which will translocate into the gene or into the nucleus and cause gene transcription and ultimately atopic dermatitis. And so when you look at this from afar, okay, there's two different ways you could stop this relay race. You could block the cytokine or the receptor directly. That's what a biologic does. Or you could hit one of these intermediate steps, right? And that is what we're doing with CIBINGO. It's going to be an intracellular target here. And because all of those cytokines that we saw from the previous slide require JAK1 to signal, it's almost like a funnel. Okay, you're able to hit all of those cytokines with just a single target. And that is what we're doing with CIBINGO. Now, one of the nice things with CIBINGO is that you have flexibility. If you're used to using biologics, you know that typically it's just one dose fits all. But here you're seeing that you have a 1 and a 200 milligram dose, and you also actually have a 50 milligram dose, and we'll talk about when you want to use that. But the recommendation here is that all patients, irrespective of their age, their body weight, their disease severity, they start at the 100 milligram once a day dose. You do that for 12 weeks. If they're not achieving an acceptable level of clearance, then you bump them up to 200 milligrams, and you keep them on that for an additional 12 weeks. And if they're not better at that point, then you probably don't want to continue therapy. Now you see here that you can use this with or without topical steroids. It's been studied in both contexts. You can take it with or without food. My recommendation is take it with food. It does help with some of the nausea that we rarely see with CIBINGO. And you want to leave the tablets intact. Don't crush it, split it, or chew. So now let's get into the JADE clinical trial program. There's 3 studies that we're going to be talking about today. These are the pivotal studies that the FDA used to approve CIBINGO for atopic dermatitis. So starting from the left, we have JADE Mono 1 and Mono 2. And as the name suggests, these are purely monotherapy studies. You can only use CIBINGO. You can't use a topical steroid. And you see the ages are actually down to the age of 12. JADE Compared, this is where you were able to do combo therapy. So you can use both topical steroids and CIBINGO. So this is more kind of reflective of what we're doing in the real world. These patients were 18 and older, so a little bit older in this group. And you actually had what we call an active control arm in dupilumab. We'll talk about what that means. All of these patients then fed into the long-term safety study. We call that JADE Extend. So what did these patients look like? So first off, these patients had to have chronic atopic dermatitis for at least a year, as defined by the Hannafin and Reka criteria. And then you see the definition of moderate to severe atopic dermatitis. This is the standard definition that all systemic therapies for AD are using. So you have to have a BSA of over 10, an IGA of 3 or greater, an EASI score of 16, and a peak pruritus score greater than 4, and this is on an 11-point scale. You can see that the severity at baseline, about 2/3 of these patients were moderate, just over 1/3 was severe, and then the baseline mean EASI score was 30. And just to put that into perspective, a score of over 20 is considered to be severe, at least in atopic dermatitis. Then moving to the right, you can see that over 40% of these patients were on some type of systemic therapy before, and actually 6% of these patients were on dupilumab before. So we do have some data with dupilumab experienced patients from this study. However, we're actually going to look at another study where we had a larger group of patients, over 200 actually, in fact, that were on dupilumab, and then we switched them to CIBINGO, and that's going to give us some data as well. When you look at the mean age, 36 years old, the majority of which are being 18 to 64. Okay, and that's half the age of the RA population that we just talked about from the box warning. You see a little bit more male than females, and more whites, about 2/3 of the patients were white, but you still had just under 1/3 of patients who were non-white. So actually a fairly good mix here. So going back to Tyler, he's in college, he has visible eczema on the skin, and he's very itchy, right? And we know that itching is the chief complaint that our eczema patients have. And so looking at the study design here, you have JADE mono 1 and 2, you have 3 arms, CIBINGO 1 and 200 milligrams, and then you have the placebo group. At week 12, this is where we measured the primary endpoints. And so EASI 75, that's a clinical trial measure, something we don't typically do outside of research, but this means 75% improvement from the baseline. Okay, and generally a patient that gets EASI 75 is doing fairly well. On the right-hand side, this is the IGA 0/1 responder rate. Okay, this is something that we're actually all doing, whether you know it or not. So when you walk into a room, you look at a patient's skin and they have no eczema at all, you call that an IGA 0. If they have barely perceptible eczema, where it's just a little bit pink, or you rub your hand over that lesion, it's just barely palpable, okay, we call that an IGA 1. And this is going to be a more stringent endpoint than the EASI 75. So consistently, you're going to see that the IGA 0/1 numbers are going to be lower than the EASI 75 numbers. And moving to the right, we have some key secondary endpoints. We're looking at a 4-grade reduction in itch. And where did we come up with 4? Well, it's been shown in a number of studies that a 4-grade reduction actually corresponds to a meaningful reduction in itch in real life. This isn't just a numerical improvement. And we're looking at itch not just at week 12, but we're also looking at earlier time points, week 2 and week 4. And then the PSAAD or the PSAD, that's just a more comprehensive assessment of symptomatology for atopic dermatitis. We're not going to get into that too much. So here we're looking at the co-primary endpoints. This is from JADE Model 2, so that's one of the 2 monotherapy studies. And let's look at the right first. So EASI 75, as I said before, isn't so much of a clinical endpoint that we're doing, but this gives us a pretty good sense of how well this drug works, right? And you're seeing that right away, the 2 different doses of CIBINGO, you see this separate from the placebo. And this is going to be a consistent thing that you see with CIBINGO. This is wickedly fast. We're talking days to weeks. You start to see the separation. Very hard to be blinded in these type of studies because you pretty much know who's getting CIBINGO. And you see in that teal line, that's the 100 milligram dose of CIBINGO. Okay, over 40% of patients get to EASI 75. That is 4 times greater than what you see with the placebo. And if you look at the 200 milligram dose of CIBINGO, okay, you're seeing clearly a dose response here. The higher dose does work better. We're seeing that in 60% of the time. Now moving to the left, we're seeing the IGA 0/1. Like I said before, a much more stringent endpoint. Just under 30% of patients are getting that with the lower dose of CIBINGO, and just under 40% are getting that with the 200 milligram dose of CIBINGO. Now, I also want you to just realize here that even though some patients, there's a couple hundred patients actually that got the 200 milligram dose of CIBINGO from the very beginning. Okay, in the real world, the FDA is not allowing you to do that. Okay, you actually have to start at the 100 milligram dose first, and if you're not better by 12 weeks, then you can escalate to the 200 milligram dose. However, if you look at the kinetics here, the shapes of the curves, you do see that at 4 weeks, okay, that curve is starting to flatten out a little bit. And that's probably the point where you're going to know whether that patient is a responder or not. Now, what about itch? Okay, and we're looking at a 4-grade reduction in itch in 2 weeks. That's the size of a sample pack of CIBINGO. And the first thing I want you to look at is the placebo group, 2%. When you have a placebo group that low, okay, that's a sign of just how difficult it is to achieve that endpoint. And you're only getting that 2% of the time with the placebo compared to CIBINGO, okay, with the lower dose, you're getting 5 times more likely to hit that 4-grade reduction. And if you look at the 200 milligram dose of CIBINGO, that's a whopping 24%, so more than double the effect that we see with the 100 milligram dose. And just from using this drug in the real world, I'll tell you, within days, my patients have reported that their itching was gone or a significant reduction in itch. And oftentimes, this will precede the actual clearance of the skin. Here we're showing you what a responder looked like. And so this patient, actually both the 2 different patients here, started with the IgA of 3, and in 12 weeks with the lower dose of CIBINGO, that's a 100 milligram dose, we see this patient got down to IgA 1. So this patient was a responder in the eyes of the FDA. However, let's look at this patient. Okay, this patient has an IgA of 4. That's the highest severity. And in 12 weeks, just don't look at the text here, just look at the pictures, okay? And I think you would agree that this patient looks quite a bit better, and this patient, I would imagine, is probably pretty happy. But this patient is actually a non-responder. So this patient went from a score of a 4 to a score of a 3, right? So if you're a score of a 3, that means you're a moderate, right? So you have still some edema, some papillation, some erythema, right? And I think this is the showing that even if you weren't a responder in the eyes of the FDA, okay, these patients are still having probably a good response, and they probably are fairly happy with their response as well. All right, so now we're getting into the JADE compare studies. The previous 2 studies were monotherapy. Here we're allowing you to use topical steroids in addition to CIBINGO, right? So we have 4 arms here. So again, CIBINGO 1 and 200 milligrams, the same color scheme. You get the placebo in gray, but now you have a dupilumab arm here in that purple color. And what I want to make clear here is that this is not a head-to-head study with dupilumab. Okay, this wasn't powered or designed to show superiority, right? This was actually just to make sure that you're studying the right patient population. It's like a positive control. That's the way to think about it. The primary endpoint was again at week 12, EASI 75, and clear, almost clear. And you see a couple key secondary endpoints. Okay, one of them being they also checked EASI 75 and clear, almost clear at week 16. And I think that's fair because if you're familiar with the dupilumab pivotal trials, their endpoint was week 16. So you don't want to handicap dupilumab of not giving it enough time to work. We also looked at peak pruritus at week 2, and this was actually powered and designed to show superiority with dupilumab at that 2-week mark. And then you can see after 16 weeks, the patients that were on dupilumab, they stopped, they switched to placebo, whereas the CIBINGO 1 and 200 milligram, they continued on to that JADE Extend study that we talked about from the beginning. So looking at EASI 75 here, and the first thing I will point you to is that placebo group. Now we're seeing 27% of patients actually get to EASI 75. And you're like, wow, that's a high placebo rate. But remember, these patients are allowed to use mid-potency topical steroids, right? And if you use topical steroids, okay, it's going to work. So don't be surprised there. Now, the 2 things that you're going to see here is that both arms for CIBINGO, 1 and 200 milligram, you see rapid separation there, right? And you see that dupilumab arm in purple, and then the 2 arms of CIBINGO. And then around 12 weeks, you're seeing that around 6 out of 10 patients achieved EASI 75 with the lower dose of CIBINGO, somewhere in the ballpark of dupilumab. These numbers are a little bit higher than what we saw before. That's because they're allowed to use topical steroids, and that makes sense because the steroids are boosted up. And we see just under 70% of patients get it with the 200 milligram dose of CIBINGO. What about clear or almost clear? Again, a more stringent endpoint. You're seeing the same thing here. Quick separation with both arms of CIBINGO. And then at 12 weeks, you're seeing about a third of patients getting to clear or almost clear, similar to what we saw with dupilumab, whereas the 200 milligram dose of CIBINGO is about 10% better. And what about EASI 90, right? This is something that we typically talk about in psoriasis, not something in atopic dermatitis yet, but we're showing you some really robust EASI 90 numbers here. We're showing you, again, quick separation with the 2 doses of CIBINGO, over a third of patients getting EZ90 with the lower dose of CIBINGO, and just under half are getting that with the 200 milligram dose of CIBINGO. So very similar to what we saw with Claire or almost Claire. And here we're looking at itch reduction again at 2 weeks. Notice that placebo group is going to be a little bit higher because these patients are using mid-potency topical steroids. We're seeing that the CIBINGO 100 milligram dose, 14% hit that 4-grade reduction, okay? Whereas with the 200 milligram dose, 30%, right? So more than double the effect. And this was powered and designed to show superiority to dupilumab 300 milligrams at that 2-week mark. Here we're just showing you an example of a patient that had an IGA of 4, so on the face, on the abdomen, okay, and in 12 weeks with using the 200 milligram dose of CIBINGO and topical steroids, we got this patient all the way down to a 0. That's the most difficult thing to do, get that 5-grade reduction, and that's what we're showing you here. All right, so now we're going to get into the JADE Extend study. I think for me, this is probably the most impactful portion of the talk. So if you haven't been paying attention yet, I would encourage you, at least for the next couple of slides, just kind of focus in here with me. So as a reminder, the JADE Extend study, this is a long-term extension study. And this is going to start here from the left. Okay, these are patients who rolled over from the parent studies. So if you were on CIBINGO 100, you stayed on CIBINGO 100. If you were on CIBINGO 200, you stay on CIBINGO 200. And then if you were on dupilumab, those patients washed out of dupilumab for 4 weeks, and they got re-randomized into the either CIBINGO 1 or 200 milligram dose. And then those patients were followed through 92 weeks. And so this is just showing you that same thing. Those patients that were on dupilumab at week 16, they stopped, 4-week washout. And then you see 130 patients got the lower dose of CIBINGO, and 73 got the 200 milligram dose. So we actually have 200 plus patients that we actually monitored from the very beginning, and we actually know how they did, right? When you look at some other studies and they're like, oh yeah, we had X% that were on dupilumab before, we have no idea how those patients actually did, right? We're just going by what the patients are saying. But in this controlled setting, we know very well how those patients on dupilumab did and how they did after they switched to CIBINGO. Now you're seeing this call out here saying that, okay, well, we're going to show you some really neat endpoints like EZ75, 90, and Claire or almost Claire after we switch from dupilumab to CIBINGO. But this is a post hoc analysis. This is not a pre-specified endpoint. So essentially what that means is that if you're familiar with statistics, if you do enough post hoc analysis and you do enough data mining, something is going to come back significant when it really isn't, just by sheer chance. We call that multiplicity. Okay, so this is just saying we can't control for that. But to be fair, so I think Pfizer's just being a little bit more conservative here. All studies are done this way when they do an open label extension. So let's start from the left. If we had a patient that was on dupilumab for 16 weeks and they did not achieve Claire or almost Claire, if you switch them to the lower dose of CIBINGO, over a third of these patients achieved Claire or almost Claire. And if you went to the 200 milligram dose, just under half of those patients got to Claire or almost Claire. And if you remember what I showed you from some of the monotherapy studies, this is pretty much the exact same numbers that we saw with some of their pivotal trials. So what this is saying is that whether or not you were on dupilumab, okay, before and you failed it or not, the likelihood of you achieving IGA 0/1 is about the same. Okay, now if you're moving to the right, EZ75, a little bit less stringent of an endpoint, but nonetheless, if you didn't hit EZ75 with dupilumab after 16 weeks, and you switch over to CIBINGO, over 2/3 of patients achieved EZ75 with the lower dose, and then 80% with the higher dose. And we can do the same exercise with EZ90. 40 to 60% of patients achieve EZ90 in patients who are non-responders to dupilumab. So I think this is actually really powerful data. These are the numbers that I'm going to actually share with my patients when I'm having those conversations about, hey, do you want to switch? If you switch, this is the possibilities of what's going to happen when you go on to CIBINGO. So let's go back to our case here. So this is Tyler. He feels fairly convinced that he may want to consider switching to CIBINGO, but he wants to have a better understanding of the side effect profile. And I think this is the area that we need to spend a little bit more time on just to make sure that we're all comfortable here. So first up, lab abnormalities. We're going to get into this, but the JAK-STAT pathway is involved not just in inflammation, but it's also for differentiation, hematopoiesis, antiviral defense, etc. So I think it makes sense to measure labs and also the lipids. So we'll talk about how to monitor these towards the end of the talk. Immunizations, always a good practice to get age-appropriate vaccinations before you start, okay? Now you see here a recommendation to avoid live vaccines immediately prior to, during, or after CIBINGO therapy, and that's just simply because we don't have the data. This hasn't been studied in that context. Now you do see here a mention of prophylactic herpes zoster vaccination, okay? We'll talk about why that comes up here, but one of the things that you'll see with all the JAK inhibitors is that there is a slightly higher rate of shingles, especially as you get to some of the higher doses as well. So what are just some special populations that you need to be aware of when you're going to put them on CIBINGO? First is renal impairment. Okay, if a patient has compromised kidney function, you might need to make a dose adjustment just depending on how compromised that kidney function is. And that is why you want to check a CMP before you start these patients. Hepatic impairment, if they have advanced liver disease, right? So if they're frankly cirrhotic, encephalopathic, they have ascites, those patients probably shouldn't go on CIBINGO. However, if they have more mild or moderate liver disease, okay, that is not a contraindication. Now for pediatric patients, even though we did study this drug down to the age of 12 and older, okay, currently CIBINGO is not approved down to that age. As far as older patients, this is true for most clinical trials. We just don't have as many patients that are 65 and older, so we just have less experience here. And what we did see, and this shouldn't come as a surprise, is that older patients tended to have more side effects, right? Or more adverse events, I should say. So more lab abnormalities, higher rates of shingles, okay? Now, pregnancy and lactation, we know that based on animal models, okay, CIBINGO, at least at much higher doses than you ever would use, could be potentially harmful to the fetus. So you don't want to use it in someone that is actively trying to get pregnant. But the good news is that CIBINGO, the half-life, being a JAK inhibitor, a small molecule inhibitor, it's hours. So within a day or so, the drug should be out of your system. And the same is true for lactation. We know this ends up in the breast milk, so you don't want to be breastfeeding while you're taking CIBINGO. So we're showing you here now the adverse rates of the most commonly reported ones, I should say, anything that happened more than 1% of the time. And whenever you see this, right, you just want to first look at the placebo group. That's going to just give you some context as to understand what's the real safety signal here, if there is one, versus what's just background noise, right? And it shouldn't come as a surprise. Nasopharyngitis, nausea, and headache, okay, those are the three that we see in most clinical studies, even in topical studies. And you do see a little bit higher here with CIBINGO. As I mentioned before, nausea can happen, especially with the higher doses of CIBINGO. So I have found it helps just to take it with food. Now you will see a little bit more herpes simplex and shingles, as I mentioned before. The JAK-STAT pathway is involved with antiviral defense, and we see this a little bit more with the higher doses of CIBINGO. Acne, this is a JAK inhibitor class effect, and we see a little bit more, especially at the 200 milligram dose of CIBINGO, but overall these numbers are low, and this is not a reason that patients discontinue therapy. Now, speaking of discontinuation, it's one thing to have an adverse event, but it's another thing to discontinue therapy because of an adverse event. And what we're showing you here is that pretty consistently for JADE Mono 1, 2, and JADE Compare, the discontinuation rates because of an adverse event was actually on par with or lower than what we saw with the placebo group. And now we're looking at the adverse events of special interest. These are the ones that we saw in the box warning. And as I said before, we're going to come back to this and actually see what's the rate in our patient population with our JAK inhibitor. And here we are. Okay, so when you look at serious infections, which means IV antibiotics or hospitalizations, okay, we're seeing about 2 out of every 100 patient years. Okay, with the placebo group, we're seeing close to 4 with the 100 milligram dose of CIBINGO, but this drops back down to just 1 out of every 100 patient years with the 200 milligram dose. Okay, so when the numbers are really small, any additional adverse event is going to kind of cause a ballooning of that number, but we're seeing fairly consistent here across the 16 weeks. Herpes zoster, as I mentioned before, is something that you just need to be aware of. Anywhere from 2 to 5 out of every 100 patient years is going to develop this. So this is a conversation I think is at least worth bringing up, right? Especially if you have an older patient, be like, hey, maybe you want to consider getting a shingles vaccine first before you start your JAK inhibitor. And this is something that even patients over the age of 18 now could qualify for if they're going to be on an immunomodulator or immunosuppressant. As far as cancers, MACE events and VTEs, we're seeing very low rates. Okay, we did see one VTE, this is a PE, at the 200 milligram dose, but what you're going to see very consistently for patients who get these type of events is that they all have risk, or as the majority of them have risk factors, right? So they're hypertensive, they smoke, obese, they're on combined oral contraceptives. Now here we're looking at now 1-year safety studies, right? And you don't have a placebo group here anymore. So you can't really compare CIBINGO to anyone else except itself. So what you want to look at are the trends. Okay, are these numbers going up with time, or are they kind of staying flat or coming down? And if you remember that previous slide, okay, when you look at serious infections, it's about 2 out of every 100 patient years. So very consistent with what we saw during the 16-week period. Zoster is still right around 2 to 5 out of every 100 patient years. Very low rates of malignancy, MACE, and we're still seeing low rates of VTEs. Now we did pick up 4 additional ones. Okay, 2 of these events happened in 1 person, but again, this all happened at the 200 milligram dose, and most of these patients did have risk factors for having a VTE. But even if you just count those patients, if you look at the incidence rate, we're still seeing well below 1 out of every 100 patient years that's developing a VTE. Now, again, there are some limitations and biases to these long-term extension studies. First off, not everyone is on the drug for the same amount of time. Some people are coming in, some people are exiting, so we're giving you averages. Also, patients who tend to do better, okay, they're the ones who tend to stay in the study, right? So we call that somewhat of an enriched or responder population, and maybe this is a slightly overestimation of how these patients are doing. But this is pretty much true for all long-term extension studies, not just the one that we're talking about today. So let's just end here with just some practical tips. How to get your patients started on CIBINGO. What are the things that you want to be monitoring? So as you said before, okay, CBC is something that you want to check because we can get rarely some abnormalities in the heme line, right? We know that the JAK-STAT pathway is important in hematopoiesis, and you see here on the bottom, okay, this is the threshold of when you would want to interrupt or not start CIBINGO based on your platelet count, lymphocyte, neutrophil count, or hemoglobin value. Okay. The other thing that you want to check is a TB. We know that the JAK-STAT pathway is probably important in tuberculosis defense as well as antiviral defense. So in addition to the TB, I recommend checking a Hep B and a Hep C. Okay. Now, I think practically speaking, the way I think about this, I ordered the labs that I normally would order for my biologic therapy, which is a CBC, CMP, Quant Gold, Hep B, Hep C, plus or minus HIV. And if you want to do a histo or a coxi, depending on where you live, that's okay too. So that's my standard biologic labs. In addition to that, I'll order a fasting lipid panel, and I'll show you why here in the next slide. But 4 weeks after you start someone on CIBINGO, okay, I will check again a CBC and a lipid parameter. And that is because in a very small percentage of patients, you're going to see that, like I said before, those platelet numbers do drop a little bit, but they tend to come back up over 3 months. So that's the main reason why you want to check it, is just to pick those rare cases of thrombocytopenia. We also see that the lipid levels do go up in a small number of patients, so we just want to follow those as well. After that, though, I'm checking labs every 3 to 6 months if those patients are doing well. You can see here on the bottom, again, this is the threshold of where you want to maybe discontinue or at least interrupt therapy based on what your platelet count, absolute lymphocyte, or absolute neutrophil count looks like. Now, on the right-hand side, you see that there is this recommendation to do full skin checks for your patients. What we did see with some of the other JAK inhibitors in patients with rheumatoid arthritis and ulcerative colitis, that there was a higher risk of non-melanoma skin cancer. We really didn't see that with this particular study, but I never think it's a bad idea just to do full skin exams on patients who are on these type of medications. Now, speaking of lab abnormalities, here we're looking at the rates of thrombocytopenia, lymphopenia, lipid elevation, and elevated CPK. And the punchline here is that these are rare. We see this more with the higher doses, and you could usually pick this up fairly early on within the first couple of weeks, which is why you want to recheck your labs again. Okay. Now the CPK, I would just call this out. We see this with most, if not all, the JAK inhibitors. It's a JAK inhibitor effect. okay? But these cases are transient. They go up and go down, right? And this is not something I'm routinely checking, okay? Now, lipid elevation, that's interesting. We do see LDL go up in a small percentage of patients, but the HDL seems to go up even more. So it's thought to be maybe a less atherogenic lipid profile. So let's talk about dose adjustment. There's very few instances where you might need to make a change in the dose. The first is if a patient has renal impairment. So again, this is why you check that CMP. If their estimated GFR is less than 60, but a greater than 30, then you're gonna have to dose a CIBINGO. So this is where that 50 milligram dose is gonna come in. So rather than starting at 100, you start at 50, do that for 12 weeks, and if you're not better, then you can go up to 100. But the recommendation is you don't go above 100. If their GFR is less than 30, right, so they have severe or end-stage renal disease, it is not recommended to use CIBINGO. For patients who have advanced or severe liver disease, so that's Child-Pugh class C, right, and I had to look this up, but pretty much you need to have ascites, low albumin, be encephalopathic, be coagulopathic. Those are the patients you don't want to be using CIBINGO in. But if they have, baseline, a little low-grade transaminitis, that is not a contraindication. Now let's talk drug-to-drug interactions, and I think this is much easier because most of us are on EMRs, and within our EMRs we have a drug-drug interaction checker. So fortunately, we don't have to memorize this, but I just think it's good to talk about it. So the way I think about this, there's two groups of drug-to-drug interactions. The first group is what can CIBINGO do to another drug's level, right? And the second is what can another drug do to the levels of CIBINGO? So let's start from the top here. If you're on a medication that inhibits a CYP2C19, right? So that's fluvoxamine, for example, that is going to increase the levels of CIBINGO because that's the pathway that CIBINGO is metabolized in. So the recommendation here is you have to dose again. So rather than starting with 100, you start with 50 and you can escalate to 100. However, if you are on a medication that inhibits both CYP2C19 and CYP2C9, i.e. fluconazole, you want to avoid concomitant use. Now, having said that, the way this was studied was patients were taking fluconazole 200 milligrams daily for a couple of weeks, right? Generally in dermatology, we don't do that. We're doing it weekly. So you can't necessarily take the exact same data here and extrapolate that to the way we're using it. But that's the way this was studied. Now, if you're on a strong inducer like rifampin, that's going to lower the levels of CIBINGO. So that's just something you need to be aware of. Now, moving down to the second group of drug-drug interactions, you want to be careful with PGP substrates. Digioxin is the classic example because CIBINGO could elevate the levels of dig. And as you know, the therapeutic window for digioxin is so razor thin that even if it's a little bump, that could be catastrophic. So this will be a flat out, don't use it with CIBINGO. The same is true with antiplatelet therapies, like we said before, because it could potentially increase the risk of bleeding, but low dose aspirin is not a contraindication. So who might your CIBINGO patient be? And then we kind of talked about why CIBINGO makes sense for Tyler. Tyler is already on a injectable biologic. He's done topical steroids. And if you look at the extent of his disease, a quarter of his body is affected, 25% BSA, and he has a moderate disease. So this patient is not responding to their treatment. And I would say in real life, have I waited this long for a patient to start CIBINGO? No, I think this is a pretty clear-cut example of a patient I would consider starting. But I simply ask a patient, okay, how much does your eczema right now impact your quality of life? Forget with where you started, right? Because some patients are like, you know what, I'm still better, but it still does affect my ability to swim, exercise, be intimate with my partners. And if they tell me that, then I think at least it's a conversation worth having about maybe switching those patients. So just to conclude here, okay, hopefully I pressed upon you that CIBINGO is a powerful, rapid oral systemic agent with the flexibility to go up and down as needed. Okay, this is a small molecule inhibitor that works inside of the cell, in contrast to a biologic, which is kilodaltons, and that's going to work outside of the cell and only block a single cytokine or two. You saw powerful skin clearance, right? Whether you're looking at EASI-90 or clear or almost clear at week 12. And we saw rapid itch relief, right? Even in just 2 weeks in the duration of a single sample pack of CIBINGO, we saw a significant percentage of patients get a 4-grade reduction in itch, which was statistically better than dupilumab. We also saw the flexibility that you can start at the 100 milligram dose and go up to the 200 milligram dose if needed after 12 weeks. And then we talked about the safety a lot here, right? Over 1,600 patients across multiple clinical trials. We talked about the box warning. It's there. It is what it is. But when we looked at the patient population that we're treating, atopic dermatitis, with our drug, CIBINGO, we saw the rates were actually much lower than you would be led to believe by looking at that box warning. And with that, that concludes my presentation. I believe now we're going to stick around and just take any type of questions that you may have. So thank you all for your attention and time.
Again, if you have any questions, please type them in the question chat pane on the right-hand side of your screen. And if you have any questions afterwards, you can always send them to info@educationalseries.com. We'd like to thank again our supporter, Pfizer, for making this educational event possible.
Thank you very much, Roxanne. And Dr. Song, that was a very eye-opening lecture. Thank you so much. That was so well done, and we had really good questions that I do want to ask you as we can go through a little bit since we have time. One question that came up, and I think you alluded to it, but is there recommended testing, evaluations, or procedures I should follow prior to starting the treatment with CIBINGO? You did allude a little bit, but maybe you can emphasize it, go over it
Absolutely.
one more time. It will be great.
Absolutely. That's a great and very practical question. So the way I think about it, and admittedly we do this a little bit differently, but my biologic labs, I do this enough where I remember it: CBC, CMP, and then Hep B, Hep C, quant gold, and plus or minus HIV. That's what I do for most of my patients on biologics. So I do those labs, and I'll add a fasting lipid panel. Okay, so that's what I would do first. And then I also ask about if it's a woman of childbearing age, what are your plans about having children in the next couple of weeks or months? Okay, if that's something that they're actively trying to do, I think you're going to have to be a little careful. I did say before, the half-life is just a couple of hours, and so even if they got pregnant, okay, it's going to be out of your system within a day or so. But I think the conservative side of me is going to say, don't actively try to get pregnant while you're on CIBINGO. So that's probably the two things that I would make sure that I ask about. And then obviously labs after you start: CBC, CMP, fasting lipid panel, 4 weeks later, and then every quarter, kind of like my Accutane labs that I've done in the past. Obviously, we're not checking as often anymore, but I think that's just a simple way to think about it.
So the next question is sort of relevant, right? You brought up the women with childbearing potential, and so is CIBINGO, the question is, CIBINGO contraindicated in women with oral contraceptives?
That's a great question. I think that's a very real world question. So in the studies, as part of the study protocol, you have to be on some type of reliable contraception. Now, that doesn't mean you have to be a combined oral contraceptive with ethinyl estradiol per se, but yes, they had those patients in there. Off the top of my head, I want to say it's roughly 5 to 10% were on a combined oral contraceptive. You're going to have to fact check me on that, and I think some of the folks from the medical could confirm. But yes, those patients, there were some patients that were on a combined oral contraceptive. That is not a contraindication. Now, having said all that, I think you have to look at the patient as a whole, right? If they're older, so let's say they're 65, right? No offense, but 65 is kind of the threshold we use. If you're morbidly obese, you have uncontrolled hypertension, and you smoke, and then you're on a combined oral contraceptive. I'm not sure why you would be on a combined oral contraceptive, but if you were, then that's a patient that may not be necessarily the first patient you want to put on CIBINGO or any JAK inhibitor for that matter. But the truth is, push comes to shove, I've put those patients on it as well, right? We've had the shared decision making. It's not a black and white no or yes, but I think common sense tells us the more risk factors you have, the more likely you could have one of these adverse events. And that is something we saw with the oral surveillance study as well. When we talked about the TNF inhibitor versus the JAK inhibitor in the RA population, those are the risk factors that we saw.
So I guess a follow-up question with that: what additional patient counseling should occur prior to starting treatment and during the treatment with CIBINGO? And then, very interesting question, do you consent the patients?
So let me address that second question. Do I consent the patient? I would say I consent all of my patients for any type of treatments that we do. Do I make them sign something saying that if anything or ever to happen, I am absolved of any legal responsibility? No, right? I don't do that. But I think shared decision making means that yes, you talk about the potential risks, but you also want to frame it in the way where the benefits are going to be there too, right? I start with the benefits actually first and then the risk. So I don't do a formal consent. I tell them that in patients that had high risk for some of these things, when they took a JAK inhibitor like CIBINGO, rarely these things did happen. Okay, that didn't happen to everyone. And in fact, even the people who had risk factors, the likelihood of having these events are still fairly low. But patients who didn't have risk factors, we really did not see this as a signal. Leon, you said that, I'm sorry, in the first part of the question, it escapes my mind. You were asking about
what additional patient counseling, right?
Counseling, got it. Yes. So very good. So I think the shingles vaccination is at least worth having a conversation about. Just from my own patient population, maybe 50% of the patients have taken me up on my recommendation. So it's not a hard and fast, you have to do the shingles vaccine. But clearly what you saw was that roughly about 3 to 5 out of every 100 patient years, you were getting a shingles event. Most of these were mild to moderate. So this wasn't like, a disseminated shingles or something that goes into the eye per se, but still shingles is pretty lousy to have. And so I do recommend they get it, right? It's not, again, not a rule. And if they're going to get the shingles vaccine, what I've been doing, and this is just my personal experience, is that you get your first dose of the shingles vaccine, wait a week, and then you can start CIBINGO, and then I don't have them interrupt for the second dose of the shingles vaccine.
In my practice now, I am asking everyone if they are older than 50 to get the shingles vaccine, regardless the drug, nothing to do with the drug, but I think it's a good thing. And now the insurances pay for it. If you're older than 50, why not to get it? So it's an easy thing to ask for. And I don't do it myself in the office, but I tell the patients, go get it from your primary care doctor or go get it from wherever the pharmacy you can get it. It's an easy thing to do. I think it's highly recommended. I agree with you.
Absolutely. Yeah.
It's interesting that the oral contraceptives are coming up from several different people, right? And I think you answered it already, so I'm not gonna repeat that. Do you actively counsel patients to avoid NSAIDs?
So that's a good question. I think where that question is coming from, I could be wrong, is that if you look at some of the other JAK inhibitors that have been studied for rheumatoid arthritis and ulcerative colitis, if you had a pre-existing history of diverticulitis and you were taking an NSAID, you had a higher risk of gastric perforation. So that is where that's coming from. I have no problems with people taking NSAIDs if they're on a JAK inhibitor, as long as they don't have a history of diverticulitis. There probably is something to be said about blocking IL-6, which is one of the cytokines that we think is important for maintaining the gut barrier. That maybe in a patient that's predisposed, you could cause or increase the risk of gastric perforation. We've seen that with biologics that block IL-6, but flat out, if it's just NSAIDs and a JAK inhibitor, I have no problem with that. And in fact, they do that in rheumatology all the time. So
that's great. Good to know. Somebody's asking a specific monitoring question. 4 weeks post start date, do you check CBC, comprehensive metabolic panel, and lipids?
Exactly. Yep. I'll do that at 4 weeks. And then if I'm going to escalate the dose to, let's say, 200 milligrams after 12 weeks, I'll check it again, maybe 4 weeks after that. And then 3 to 6 months. And quite honestly, now I have a lot of real world patients out of clinical trials that are closing in on that 1 year mark that they've been on the therapy for. It's been really boring set of labs, to be quite frank. I really haven't seen much. And so for some of those patients, I'm going to start spacing them out to every 6 months, maybe even longer.
So I have a question. Doubling the dose, do you start with without trying the lower dose, or do you always wait and see what's going to happen?
Yeah, that's a great question. And I'll be honest.
In your practice, of course.
Yeah, in my practice, so when the FDA first came out with the requirement for all the JAK inhibitors, pretty much, right, that you have to start with the lower dose before escalating, I was a little bummed, right, because I'm of the training that higher is better early up, and then you can taper it back down, right? So whether that's cyclosporin, 5 to 6 mg per kg, or prednisone, 1 to 2 mg per kg, and then get them down. That's the way I train. That's the way I do it. So with the JAK inhibitors, I'm like, gosh, I wish I could do the higher dose. I've been pleasantly surprised, Leon. Even the lower doses of CIBINGO, right, at the 100 milligram dose still works very, very well. And I could probably count on one hand how many patients I had to escalate to 200 milligrams. But even if I do escalate that, I could still, in many of these patients, drop them back down to 100 milligrams. And so on label, you have to start at 100 milligrams for 12 weeks. And then if they don't achieve a certain level of response, then you could go up to 200 milligrams.
Great to know. I think that has been my experience too. But I think it's good to know that follow that. Okay, so I think we are almost running out of time. And one comment, I have to say this, it says not a question, but Dr. Sung was great, very enthusiastic and knowledgeable. So I full-heartedly agree. Thank you so much. That was really well done. I appreciate it. So thank you everyone for attending this evening's educational series. And we do want to thank Pfizer, our supporter. Thank you, Roxanne. And I think Roxanne has some last minute announcements.
Absolutely. And please join us for our next 2 webinars where Dr. King is going to be talking about a targeted approach to the treatment of non-segmental vitiligo on November 22nd, and also our accredited program on December 1st on an update on atopic dermatitis and skin of color, the dermatology and allergy perspective. Thank you, everybody.
Thanks, everyone. Have a good night. Bye-bye.
Thank you.